Okay, well, hello, everyone. Thank you so much for joining us. We're all very excited to have you join us for Integrating Genetic Risk for General Dentistry. We have a very exciting session planned tonight, and I know that I'm excited to unpack some genetic testing information. We're just going to start off slow here and allow some more people to join in. But just while we're waiting, just a little bit of housekeeping right off of the bat. This session is being recorded, so if something pulls you away and you have to leave for whatever reason, don't panic. You will receive a recording within the next week or so. If you have a question, we're going to reserve the questions until the end. So use this Q&A function. For most of you, you'll see it at the bottom of your screen. If you want to use Q&A to type in any question that you're looking for an answer for, that just helps us to keep it organized. If you're just saying hello or have a comment to make, feel free to use that chat function. There's a lot of us here on the panel, so if you do want to only see the active speaker, what you can do is there's 3 little dots at the top of my face and everybody else's faces. If you click on those dots, you can pin me, you can pin Dr. Graham, you can pin Kathleen, and that'll be the only speaker that you see. You also have the option, you'll see view in the top right-hand side of your screen. There you can have it on gallery view, or you can have it on the speaker view. So if you find it overwhelming to see all of our faces at once, you do have the option to adjust what you're seeing. All right, I think that's it for housekeeping. So let's dive right in. We have Dr. Lou Graham, who's going to start off the session tonight. He's a general dentist and part of Catapult Education, and we're very, very excited to have him here with us this evening. Dr. Graham, I'll hand it over to you.
Thank you, Beth. So I think my portion to start this wonderful night off, and this could be kind of an epic night. This is a change in your journey out there for everybody listening in. So for the past 60 plus years in dentistry, the initial exam has routinely included evaluating one's oral health, you know, the restorations, caries, occlusion, maybe the TMJ. Dentists would routinely take an FMX, horizontal or vertical bite wings, maybe a Panorex. That came around in the late 60s. Routinely, we should all be doing periodontal probing. I mean, it should be routine. And then we would always, in our initial exams and recall exams, review medical and dental histories. Well, the medical and dental histories have become even more involved as we continue to be educated as a profession. So, for example, when we look at a medical history with acid reflux and high blood pressure, I'm thinking immediately potential sleep apnea. Then I'll go into family and dental history, look at the arch and maybe some signs and maybe have an additional sleep apnea form. Then as I'm going through the medical history and I see diabetes and smoking, first thing I'm thinking is potential periodontal involvement. So now we have the medical history, and the more we learn about the medical history and familial history, we then go to the dental history. And when we're looking at cavity-prone patients or periodontally prone patients, and we're looking at both the dental history, medical history, these are huge signs and opportunities before even we walk into the room to have an idea of what's going on with that patient. So with such, what are we doing? We've assessed risk factors. So then we would do our thing, meaning our restorative work, our implant work, our endo work, our ortho work, whatever our thing is. And routinely we'd guide the patients to do their thing. What's their thing? Brushing and flossing. That's what you got to do. And we'd give some nutritional counseling, but it's really brushing and flossing. That's their thing. And yet, all too often, we would be underwhelmed in year 5, in year 7, in year 10 with the results and wonder why were we having these issues of recurrent caries or periodontal issues, whether around implants or our restorative solutions, our ortho, any of our treatment. And then we would question ourselves. Everything looks great. I hope it does when you deliver it or when you finish a case. But years later, and now we're looking at this going, what did I miss? What did we miss? And then we'd ask ourselves, could I have diagnosed these risks better? So then what happens is we've upped our diagnostics. And when I say we've upped our diagnostics, now we have, for example, tissue fluorescence for evaluating oral mucosal abnormalities. We have CBCT imaging. I haven't taken a full mouth series of x-rays since 2015. Yet you heard me right. I take a series of horizontal or vertical bite wings and a CBCT because the CBCT with less radiation shows me so much more than an FMX. So why take an FMX? More diagnostics, digital scanning. Now you have so many opportunities with digital scanning, not just to scan an arch, but actually diagnose things and issues in an arch. And now you have 2D imaging with AI, and 3D imaging is right around the corner. So all of these are going to enhance our diagnostics. And yet, even with all these advancements, are there inherent risks that we could still be missing? And the answer is yes. So tonight, that's why we're here. And I'm so glad I get to share this with Kathleen, who's going to be our closer tonight. Beth is going to come from a dental hygiene standpoint. Suzanne's going to walk you through the system. Dr. Stephen Moore is going to explain to you really what this genetic profiling is all about. And hence the course, the next era in dental diagnostics. I really think you'll go back to tonight and realize this was a transition in your career about dental diagnostics. And really, this is about genetic profiling. Why knowing can really create better outcomes. So we're going to go to a quiz. And the quiz question is going to come up on your screen right now. So Beth is going to show this, and I want you all to answer this. Genetics, true or false, has a substantial role in both caries and periodontal risk factors. Not a trick, true or false. I want you to vote. We won't know who you are. It's just a true or false. And I'd say, Beth, that's enough time for someone to have answered that question. So let's take a look. So 96% of you believe that there is a role of genetics in caries and periodontal risk factors, which is absolutely great because the answer is true. Now we're going to get to this. All night tonight, we're going to get to this, both caries and perio. But let's go to a second question. And Beth's going to put this up. Can a patient's genetic code dictate a more caries-prone patient? True or false? I should have some music going. And Beth, let's see the answer. Okay, it went down a little bit for the genetic code for a caries-prone patient, but still 93% of you believe that there is a genetic code that can dictate a more caries-prone patient. And you're correct. That answer is true. So let's just take a deep dive here. Over 90% of you now say there's a genetic role in perio and caries, and yet we're not testing. Hence why we're all here tonight. So now I want to go back to the 1930s. Since the 1930s, with original studies on twins and caries, there have been countless studies thereafter demonstrating a genetic involvement with patients at risk for caries. So we're going to go back 100 years And I'm showing you all of these studies, and this is just a sample, over 100 years of genetic research in caries. Who would have known? I didn't know this in dental school. I want to focus on the Vipahome study. There's a lot of social issues on this study that we're not going to get into. The study goes back to 1945 and was conducted over 8 years. Individuals were split into two various groups and treatment groups. So you had a control group and treatment groups. And the aim was to determine the relationship between diet, the frequency of sugar intake, and dental caries. Sugar was administered in two forms: a solution during meals, or sticky food, bread and toffee, in between meals. And the study positively established that sticky sweets consumed between meals rather than during meals more significantly increased the rate of dental caries due to carbohydrates. Yet, the investigators ignored two huge issues. The first was, despite the sugar consumption of various subjects, so they would have the sugar consumption, they did not develop carious lesions. Secondly, the secondary subjects developed carious lesions, even though they were not consuming sugar substitutes, and they got cavities. So it wasn't all directly attributable to sugar. So when we're talking the caries dilemma, the studies now over these 100 years say that genetics can actually affect up to 65% of how susceptible someone is to dental caries. And these genetic factors that can contribute to dental caries include tooth shape. So you have a crowded or really tight teeth in a dentition, they're more caries prone. You know that. That's genetic. And there are more challenges to home care. Enamel. Genes play a role in determining the composition and the structure of tooth enamel. And this will again show vulnerability to caries. Salivary factors. Now, this may be new to you, but genetics actually has a very distinct role in the amount of saliva a person produces, as well as its composition, thin, natural, ropey, thick, yuck, the flow rate, the pH, the buffering capacity, all things you know, but there's a genetic involvement. And the immune response, because caries is an infectious disease. And lastly, taste. Genetics has a very important role in taste. So if someone has altered taste and they can't taste sugar or sweets or sour, and they're going to want to consume more of that, that can make them more caries prone. All of these things are genetically involved. So I'm going to show you this, I think, amazing diagram. This diagram shows caries. And what we originally thought, or what we were trained was that you'd have strep mutans and maybe some lactobacilli as the microorganism. And then they would be consuming the carbohydrates over time. And a host, obviously, could be affected maybe by saliva, by immunity, by taste, by genes. All of those things could have some relationship on the host tooth. But let's look more carefully at genetics. Genetics has a direct role and should be expanded from this traditional diagram to include how it involves microorganisms, how it does dictate the surface dentition, how it can alter taste, how it can alter immunity, how it can alter saliva. So I believe, and the research believes, that genetics has a huge role in caries and the process and evolution of caries. And now we get to peria, a disease characterized by the destruction of the periodontal complex of soft and hard tissues, which is really caused by a combination of dysbiotic microbial communities. And you all know that. And then you have an abnormal potential immune response to these periodontal and in your periodontal and gingival tissues. And for decades, research has shown genetics has a huge causal relationship with periodontal disease. So we're going to go back about 27 years to Kornman. And Kornman showed that if you have a microbial challenge, so the initial challenge, how the host responds by releasing antibodies and PMNs can often be dictated by the environment and acquired risk factors along with genetics. And those genetic risk factors, environmental and acquired risk factors, can also affect how the connective tissue and bone metabolism really work together in fighting off this disease. So as the disease starts to go downhill, you'll see more clinical signs. So how the host responds was even brought more into effect by Offenbacher. Offenbacher study in 2008 showed that, for example, if you see someone in your practice who's smoking, they're 5 times more susceptible to periodontal disease, red flag. 2.8 times more if they're a diabetic, red flag for perio. Obesity, red flag, increased perio risk. Biofilms, obviously the certain bugs in their biofilm, risk factor, and we could be testing biofilm. Then you get to the genetic and epigenetic, where epigenetics is this huge emerging area in scientific research that shows how genes can be changed in a sense, and they're not necessarily always set in stone. And then you get to the biologic phenotype and how the phenotype can be influenced by genetics and the environment, ultimately to each individual's phenotype. That's Offenbacher's. And then there was another causal addition to periodontal disease, and that's stress. So you had stress, obesity, smoking, diabetes, and genetics, and all of these relate to more than just bugs, brushing, and flossing, and scaling and planing and periotherapy. It's much more complex than that. And the latest research really goes into show we're talking about an inflammatory disease that really starts with inflammation. As it starts to go from stage 1 to 2 to 3 to 4, and how we end up treating this disease and how it resolves is often just not related to inflammation, but related to so many other issues besides hygiene therapy, brushing, and flossing. Because the bottom line is, when we talk about the periodontal dilemma, all immune responses are not created equal. And that's why we're here tonight. Because we have to understand the additional risk factors. And now I'll hand it over to Dr. Stephen Moore, and he's going to explain about this unique AI genetics test. Thank you.
Thank you, Dr. Graham. So I will just, I am going to share my screen. So good morning, or good afternoon, sorry. Good afternoon, everybody. Thank you for taking your time out here today to listen to this presentation. Just confirming you should now be able to see my screen. All right, so a little bit about myself. So my name is Dr. Stephen Moore. I am a geneticist by training, and I work with AI genetics. So in the next 10 to 15 minutes, I'm going to walk you through the oral risk, and where we're going to apply what you just heard from Dr. Graham, where what we know is there's a genetic component, and now with this test, it's now an actionable item. So briefly, this is the kit. This is what you would receive in your clinic. It's relatively straightforward package. And what you can see is there's It consists mainly of a swab that collects cells from the mouth, either cheek or the gums, and then you just put it back into the solution and mail it out. So the actual interaction with the kit is relatively straightforward. So what this test is we want to assess the individual's risk or profile in developing two of the most common conditions. These are, as you've heard, dental caries, as well as periodontal disease, which you know very well. What happens at the end of this is once the kit is received, we have it analyzed at Mount Sinai Hospital here in Canada, and we give you a report, and the patient will receive a report compiling 3 different pages. So I'm going to walk you through those different pages. And what it is, it's plotting the individual's relative risk in developing periodontal disease or dental caries against the standard population, showing their exact risk relative to everybody else. So I'm going to first walk you in 3 phases. So how did we get to developing this? First of all, we looked at the market research. We wanted to see if there's a problem that had clear, preventable approaches. And what we did was also look through global peer-reviewed studies to look for association studies in those areas of involvement. And what we found is peries and dental caries are very common, 11th and first most prevalent diseases, looking at a global study. And as you just heard from Dr. Graham, there's a huge genetic component to this. So it is well suited for looking at it from the genetics perspective in the test. So we did a broad initial review of the global peer-reviewed, these are genome-wide association studies, and we did find that these studies, a lot of them did include a lot of the genetic markers for these conditions. And that was perfect for setting up a test. So then we went into a second phase where we're doing a deeper dive. We're looking at the exact genetic markers that have a strong correlation. And these are strong correlations that have been published, which you showed from Dr. Graham. And these are correlations with actually disease outcome. We then can now rank these markers and look for them in these genome-wide association studies to see if they're actually being reported out compared to the general population. And from that, we defined 25 individual markers for periodontal disease and 35 markers for dental caries. And these are well-defined, researched markers that have known associations with these 2 conditions. So it's the most inclusive test on the market. The third and final phase before developing the panel that we do our assessments with was we developed what's called a polygenetic risk score. And this is developed actually out of a lot of research in the medical field. And they're trying to look at the polygenetic risk score in looking at general population or screening protocols for various cancers. Breast cancer is one, for example, and also prostate cancer. Shown here on the right is one of the study results where they looked at the polygenic risk factor for prostate cancer. And you can see there's a shift in the mark based on a person's individual profile. So this is now being adapted for the dental market, which we're hearing about today. So in this case, what we found was that the periodontal disease, the markers that we were checking for reference, we're looking at a population that the individual is being compared against is 2,500 patients. So this is a very good overview of the profile of the general population that they're being compared to. So looking at the genetic profile, we developed a methodology looking at specific gene changes within that individual's DNA sequence. And like we said, these are mapped and published genes changes that have linkages to the diseases that we talked about. These are changes or markers evaluated by the test, and we look for the associated risk in developing that trait. And this is again supported by high-quality peer-reviewed scientific publications. The final thing is we've passed all the analysis, quality control metrics to evaluate this test, and we use it for subsequent risk testing. So this is looking at the first page. What is your actual patient going to be seeing and trying to look at and understand? So what we see here is on the left, you see the results of your periodontal disease risk. You see the curve there, that's the general population. And where that patient individually falls is shown at your risk, a 95 percentile in this case. So this patient falls on the far right. When we look at the caries risk profile, it's the exact opposite. They're in the 5th percentile, so they have a low risk in their genetics for developing cavities. All right, so when you get this result and you're finding that you're the patient or the individual and you're counseling this patient, you have to start, this allows you to build that conversation around what would potentially change in your clinical approach or dialogue with this patient if the genetic profile does put them in a high-risk category. So expanding the first page of the report a little bit further, underneath the visual, we have separated out a little bit more details so that it helps guide the patient into what they're interpreting. For example, it looks at what out of the 100 patients, your risk is higher than 95 other patients. So it's giving kind of an understanding of what they're actually visually seeing in their report. And the same is also done for the polygenic risk or for the cavities. The second page of the report, we give a little bit more information about what periodontal disease really is. So when they're reading the report, they can reference about what it is and how often it happens, a little bit of information that might help them understand the report a bit better. It also includes next steps at the bottom, explaining that this is to help them develop a conversation with their care plan and help understand and influence how they're going to be managing their profile. The final page I'll bring to you to is basically the genetic side of it. So we explain and are transparent about the testing methodologies. We talk about what it means, the risk categories, also the test limitations. This was helped and designed by medical director of a genetic test facility here in Canada. And this is what you would typically see if you went into any medical practice and got a genetic report. We also back this up with the various references that we use to conduct the study. So with that, I believe we'll save questions to the end, and I will now pass it over to Beth.
All right, well, thank you so much, Dr. Moore. Being a very visual learner, I really appreciate the graphs that you showed, and it's just so interesting to see that that's what our patients are going to see when they get those results. So I'm going to just take a moment and offer some insights just from a dental hygiene perspective. I think that each member of the dental team offers something unique. So they have a unique relationship with the patients and a unique sort of point of view. So I'm going to take a couple of minutes just to talk about the dental hygiene perspective and really sort of lean into the fact that we are masters of prevention. Before I dive into that, I just want to sort of set the stage a little bit and pose a question to all of you. So you can just use the chat for this, but if you could just list a couple other professions, so other than dental hygiene, a couple other professions that come to mind that would specialize in prevention. This might be rhetorical for some of you, but I would love to see some responses in the chat as well. So there's a few. You know, I think about, you know, massage therapy to some degree, maybe chiropractics to some degree as well. But the truth is, the healthcare model is largely reactive. You know, extremely few focus on prevention the way that dental hygiene does. And moreover, even for those few who do look at this from a preventative point of view, they're not necessarily given the amount of time with the patient. So the frequency to which we see these patients is very unique. And then second to that would be the amount of time. As a dental hygienist, I feel like there's never enough time, but truthfully, if we look at the number of minutes we're spending with the patients, it's pretty unique. So being focused on prevention, coupled with our unique ability to get to know our patients on a very deep level, places us at the forefront of change. I do think as dental hygienists, we really need to lean into that superpower. And I think that genetic testing could get us there. Right? Dental hygienists, we truly are masters of prevention. Our hearts and our intentions are geared towards preventing patients from potential disease and harm. But I do wonder if we can be even more proactive. And if we think about caries as an example, we have wonderful charts like with Canberra. You know, we look at diet analysis, we look at lifestyle factors. But really, the best predictor for a carious lesion is one or more carious lesions within the last year or two. Along a similar vein, if we talk about periodontal disease, I believe the probe was invented in 1936. And since then, that has been the gold standard. And this measurement, many clinicians make their preventative decisions based around that pocket depth. And I think I'm not trying to take away from the importance of CAL and radiographic interpretation, indices. These all tell a story, and they give us such valuable history for our patients. And they're critical elements. But is there something that we can do even before that? Before that first carious lesion pops up? Is there something we can do to get ahead of that? And I think that's what I love so much from a dental hygiene perspective when it comes to a genetic test. Another aspect that I really do love is this objective data. So much of what we tell our patients as dental hygienists is based on our interpretation and the dentist's interpretation of the radiographs, the measurements that we have taken, the bleeding points that we have measured and articulated to the patient. I love the fact that there's this third-party report that the patient is receiving, and then we receive it, and we get the opportunity with them to go over the results, digest what the result is saying, and then we ask, okay, now what? So as much as we, the dental hygienists, are leaning into this superpower of prevention, our patients are leaning into us more as their partners in saying, okay, I have this genetic predisposition. Is my fate now signed, sealed, and delivered? Well, no. That's what's so amazing about the specific diseases involved here, is that they're actionable and preventable. And that's where we thrive. So I see this as being very beneficial for many of our patients, absolutely. But I think there's two scenarios that I see. I see it being fundamental for new patients. You know, it's starting off on the right foot. So starting as a new patient coming into the practice, you're already kind of giving this proactive mindset. You know, right off the bat, you're telling them that this treatment is going to be customized to their genetic code, with them in mind, very specialized and geared towards them. And then for our patients of record, even though we have been seeing them for some time, it can also offer some insights as to, okay, maybe we've seen them for 20 years, all right? And there's a little bit of frustration around not responding to treatment maybe the way that we had hoped they would, or they had hoped they would. Or they're using the exact same tools as their best friend or their coworker. And yet every time they come into the practice, they're told that there's another carious lesion or the pocket depths are increasing. So it could unpack some of the reasons why. Doesn't mean their fate is sealed, but maybe we need to act a little bit differently for you. Be a little more proactive, maybe a little bit more intense with the treatment that we're going to provide for you based on your genetics. And all of this, in my opinion, is empowering, rather than, again, being something, oh, great, I guess that's my story now. No, it's something that we're going to take action on, right? So patients who understand the genetic basis of their condition may feel more empowered to make informed decisions about their healthcare. This knowledge can also demystify their condition and make the treatment process less intimidating. You know, human nature is going to kick in. Once they see that report that says that they are genetically predisposed to a certain condition, they're going to start to become more inquisitive, right? They're going to have skin in the game. They're going to ask us more questions. That lean in happens where they see us as their partner. And the opposite can be true, right? Again, we mentioned our patients of record, and dentistry can sometimes come with a lot of fear and anxiety, or maybe frustration, guilt, lack of motivation, and loneliness, right? When an assumption is made about an individual's lifestyle and choices, and not enough compassion given around the potential for genetic factors, sometimes shame can be associated with that. Getting back to that empowerment, the opposite can be true if it comes back and it says, yeah, you're at high risk for periodontal disease, or you're at high risk or even moderate risk for caries. Then the patient can say, okay, that makes more sense. And there's that validation. They feel seen, heard, and understood. And the same can be true even if they haven't had a negative history, right? We're starting off right at the beginning. They get that report. And rather than them feeling frustrated by it, we empower them to say, we're going to partner together and we're going to make sure that this doesn't happen for you. So I'm going to close off my portion by saying genes and heredity are the groundwork, while lifestyle can stabilize the environment or crumble it. So we certainly don't want to position genetics as this kind of definitive crystal ball, but this is why a test like this is so special, right? It's not it's not an entertainment genetic that comes back and says, you have blue eyes. Well, thanks, I knew that, right? Or you are tall, right? No, it's something that is actionable. We can take action on this and create change. So I will end with this quote. And, I think that this test really gives us the chance to rewrite our patient's history, or, let's tell a different story. And that is, from a dental hygiene perspective, why I'm so excited about oral risk. So I'm going to hand it over to Suzanne, and she's going to walk us through how the test actually works.
Thank you, Beth, very much. Hi, everyone. I'm just going to screen share here. So I have two short videos to share with you. The first one is on the oral risk process to show you from start to finish how simple and easy it is to use, and how you can see it could be integrated into your clinic.
How it works. After purchase, go online to create your profile. Follow instructions and mail the kit back. We analyze your genetic profile and provide insights, helping you and your healthcare provider build a personalized health plan.
Second video here has to do with our portal. So we have customized a user-friendly portal that allows you to register your profile, the test itself. You can track the progress of the test, and also it's the portal where you will receive your results. So I'll show you an overview now of the portal.
At AI Genetics, our vision is to realize a future in healthcare that is patient-centered, personalized, participatory, and preventative. Our portal was developed with this vision in mind. Customers can access our portal at myaigenetics.ca on their mobile phone or computer. Once logged in, you can create and customize your profile. You can register your test kit and view the status of your DNA testing. And lastly, you can review the results of your genetic testing report. We value your choice when it comes to how your data is used. You can choose to provide your healthcare professional access to the results of your genetic testing. Within the platform, they can view the results and learn more about your genetic predisposition for various diseases so that you can create a health plan that is focused on prevention. The data that we obtain from the portal is safely saved and encrypted, and it enables groundbreaking discoveries by our AI systems. Ultimately, the portal was created with you in mind, so you can take your health and wellness into your own hands. Unlock your potential, know your code.
So the last piece for oral risk, the oral risk portal, is the clinic level. Now that is something that our development team is finalizing right now. And what that will allow is for a clinic to register as a clinic and then sign up the patients underneath the clinic, which will allow you to be able to log in as the clinic, see all of your patients who have taken the test, and be able to monitor and track their results in one easy login. So that will be ready in about a week's time. We're very excited to be able to offer that option to clinics. And with that, I will pass things along now to Kathleen at the RDHU.
Okay. Just share my screen here. Sorry, hang on one sec. Are we all good? Okay, so I wanted to talk to you tonight about AI genetics from a marketing perspective. AI genetics offers us an incredible opportunity to elevate our practice and enhance the care our patients receive. The marketing opportunities for AI genetics, we can market this to our existing active patients, and it's a great opportunity to offer it to patients who are possibly inactive, who haven't been in a while. You can really use this as an engagement campaign. We can also attract new patients by using AI genetics. And you can create an AI genetic campaign to attract new patients. It can be a nice lead magnet or lead generator for your practice. And you can use this through Google Ads, through social media, connecting with people in your area. And this is really revolutionary technology and will make your practice stand out from the office across the street. When you really think about it, this is pretty amazing cutting edge technology. And it's something that people are going to talk about. And I don't know about you, but I've been to several dinner parties where people didn't realize what I do for a living, and somehow the dental appointment comes up at the table, and I always enjoy listening to what people are saying. So you just think about this amazing technology that people are going to experience, and they're going to share it with their friends and family. And then also think about like the kindergarten, you know, when the parents are dropping off the kids and all the conversations that they have, that they've had their little Johnny tested for to see if he was predisposed to dental caries or periodontal disease. It's a real game changer for your practice and for your patients. So I want to take a look at who would be the ideal patient profile type that you could offer AI genetic testing to. So we have the high risk of dental issues, patients with a family history of dental caries or periodontal disease. Preventive care enthusiasts, those are who are proactive about their health and interested in preventive care measures. Patients with frequent dental problems, so individuals who have recurrent issues with cavities or gum disease despite their regular dental care. And new patients, providing a comprehensive initial assessment to tailor their dental care plan. Patients with compromised immune systems, so individuals with conditions like diabetes, obesity, or autoimmune diseases that could exacerbate dental issues, and vice versa, dental issues that exacerbate the disease. Patients with a family history of systemic disease, so individuals who have a family history of systemic diseases such as Alzheimer's, diabetes, heart disease, and more. Patients concerned about their children's dental health, offering early intervention for children who might be genetically predisposed to dental problems. And patients planning major dental work, like those preparing for extensive dental procedures or orthodontic work. These are all great potential patient profile types. The list goes on. Patients interested in holistic health, so individuals looking to integrate their dental health with their overall wellness plans. Regular dental hygiene patients, encouraging those who visit for regular hygiene appointments to take the next step in personalized care. Patients in high-stress jobs, we all know that stress can impact oral health, making preventive measures even more critical. And then lifestyle choices. So those who smoke, using vaping or alcohol, diet, we know that these are all at higher risk of dental caries and periodontal disease. And you could keep going. The list is so long. So I really encourage you to take the time and create your own patient profile type. And by focusing on these patient profiles, you can ensure that those who will benefit the most from AI genetic testing are given the opportunity to improve their dental and overall health proactively. So I encourage you again to create your own list and just think about those patients that are in your practice and who do you think would be great to have this tested on. So once we have the patient profile type, how do we communicate this with our patients? And so this is where you're going to craft a headline that will make your current and potential patients eager to learn more. And this could be whether it's through an email that you send out or a post that you create. So it's not just in general, like we offer AI genetic testing. That is not captivating. So you really want to think about who are your potential patient profile types and then create a compelling headline. So you're actually speaking to that type of patient. So here's just some examples that I came up with. Revolutionary testing to determine whether you are predisposed to cavities and gum disease. Click here to learn more. The future is here. Take an AI genetic test to determine if you are predisposed to cavities or gum disease. 5 things you can do to prevent cavities. Do you have gum disease in your family? Get genetic testing for only such and such dollars to discover if you carry the gene and get on your prevention plan. Unlock the secrets of your dental health. Discover your genetic risk today. Prevent dental problems before they start. AI genetic testing for optimal oral health. The future of dentistry is here. Personalized care with AI genetic testing. From prediction to prevention, how AI genetic testing can revolutionize dental care. So you see these headlines will capture attention, highlighting the innovation and benefits of AI genetic testing and position it as a must-have service. And so once you've done this, you've captivated your audience, now is the time that you would educate and motivate them to want to learn more. So you would send them an educational brochure, or perhaps it's a part of an email campaign where you're letting them know what AI genetics is all about, and then you encourage them to come and take the test. So in order to really make this happen, like we all know, like trying to implement something new in your practice, it's not an easy task. It's really important that we have buy-in from the whole team, right? So you want to have a system in place so that everybody's on board. You just don't bring it into your practice and then expect everybody to know how to do it. So you want to make sure that the front team is very aware, and so that they can support the back team as well. So the number one thing is you have to educate the team. You want to designate a leader. So you want to have somebody who's really excited about this program, and you want them to be able to support the team. So if they have questions, if they have obstacles, they're going to be the ones that are going to place the ordering. They're going to be the ones that have the list of who had the test, so they can follow up and make sure that everything is in place. So once you've done that, you want to create your plan. So creating your plan, you want to create your patient profile list. And you can use the ones that I just mentioned, and you can also add to it and have your own. You want to look at the scope of visit. Is this going to be included in exams? Are you going to include it in your new patient exams? Are you going to include it before starting any major dental work? Are you going to include it as a standalone test? If you're bringing somebody back into the practice, perhaps that is a possibility for you. You want to look at how long is the appointment. So these are all things you're going to go through with as a team and come up with a plan so that everything is just running very smoothly. And then treatment room. Are you going to have a designated treatment room? Some people have that op that's not fully utilized, so perhaps it's that, or if it's part of the treatment or part of the assessment, then you know that they'll be in that treatment room. Billing codes. Everybody always wants to know about the billing codes. These are potential billing codes that you could use. The 04101, 04102, and then the lab fee is 09111. And these are microbiological test codes that you could potentially use in your practice. But you also want to talk about insurance and that it may or may not cover, but emphasize the long-term savings in time, pain, money, and that can all be the discussion, and so that you can even do role playing within your practice. So you could have one person be, having the test, and the other one, or the one person offering the test, the other one kind of giving them some, questions or giving them some roadblocks. And that way you can always be prepared when you are having those conversations with your patients. You want to determine the pricing, so everybody's on board. Information material, get some brochures and make sure you always have them on hand. The results delivery, so how is that going to work? Are you going to have follow-up consults? Are you going to have a phone call? What does that look like for you in your practice? And then you want to determine the role of the team for each team member so that they know what their role is with this whole thing. So you want to review the talking points with your team members as well so that everybody is on the same page. It's so important. By addressing these points, you can ensure a smooth implementation process that benefits both your practice and your patients. Okay, so the first thing is we're going to systemize and create your plan. I created a worksheet that I will send you in our follow-up email, the after email. So it'll have all the questions, all the things to consider as a team before you launch. And then I always encourage you to have your day designed. So really look at who's coming in. If you can do it the night before, that's great. You know, that you can use this for so many different things, not just the AI genetics. But if you are starting this program, really give it your all for 3 months, and then it'll just be running so smoothly. So what I recommend is look at your day planner and then select 2 patients for that day. And this will get you used to that conversation, put it on your day planner, AI genetic test, and then away you go. We have this track and measure. So I'm a big tracker. To me, if I don't track things, I don't get things done. So what I recommend is you print this, you put it in your lunchroom or in your meeting room, and then just have every person who's offering, every clinician, do a little checkbox. So, you know, at the end of the day, you don't have to put your name or anything, just check. And then at the end of the day, you can see how many patients got tested. And then this is a great way, 30-day tracker. So perhaps you meet as a team once a month just to discuss where are we going, what are the obstacles, how are we feeling about it. And this is just a way to get this program be successful. And, you know, this whole system you can do with anything that you're bringing into your practice. It's just something that works. So I'm very passionate about the patient experience, about marketing. So I hope you enjoyed my portion of this presentation. Thank you so much for joining us. I'm going to pass it on to Anna, who's going to take over and talk a little bit about pricing. But if you have any questions, please enter them into the Q&A and we will answer them to the best of our ability. Thank you.
Thank you, Kathleen. I'm just going to share my screen here quickly. So at Curion, we're extremely excited to bring oral risk to the market because knowing a patient's risk can empower clinicians to make more strategic decisions about their patient's care. We're incredibly optimistic that oral risk will in fact enhance the collaborative process between clinician and patient, ultimately leading to the best possible outcomes. So moving forward, as we know that this is a question that will always arise, this is going to be the pricing for the oral risk kit per patient. So the regular price is actually $209. If you purchase 5 or more kits, it will be $198.55, 10 or more, 15 or more. As you can see, the more kits that are purchased for your patients, the price will go down. To thank everyone this evening for joining us and then I would like to invite all of our panelists back at this time, and we're going to go ahead and answer some of the questions in the Q&A. If all of our panelists can turn on their videos and unmute themselves, that would be great.
Okay, I can tackle some of these. Hi, my name is Shaz Khan. I'm the CEO of AI Genetics, and we're very happy to have Oral Risk as our first commercialized panel. I think Dr. Stephen Moore there is typing out for Oral DNA Labs. Yeah, I mean, just to talk about it, that has to do with oral pathogens, and whereas our test is to do with the human DNA. So, you know, apples to oranges, really. You can combine the two together, but your predisposition is really what would be the first thing of how you would tackle an oral issue like that before you get to the pathogens. So the pathogens also vary on time of day, time of month, what you eat, and all those types of things, whereas your DNA doesn't. The only thing is that, and I think this is kind of an answer to one of the other questions as well, you know, how well do clients receive it? You know, will they be like, what's the point? Well, no, there is a point. You don't have to worry about that because Dr. Graham covered this when he talked about epigenetics. So epigenetic expression is a big thing. It's a new part of genetics. It allows you to actually modify your social instances, especially with kids. There's an instance of methylation of DNA that could happen, and that epigenetics allows you to modify the gene, so not necessarily will it express its code, especially for something bad, right? So there is things that you can do and your body can do to prevent it, and that's why taking the test is very important, because you can do preventative measures, and your oral healthcare provider would do that for you. I'm just going through the Q&As. The rest of the team can just jump in if you guys have an answer ready faster than I do here.
So Shaz,
Yeah.
from a clinical standpoint, I'd like everybody to understand that the way I look at this test, it's a test that I would be providing for my patients, my hygienist would be providing for our patients, who we would feel would be falling into either the high risk or moderately high risk categories. This is a once in a lifetime test because you're basically testing genetic markers. The oral DNA test, which I am a big fan of, and other genetic saliva tests or salivary tests, those can evaluate how your treatment is improving beyond just bleeding on probing, for example. So you can evaluate PG, AA, BF, and others. So those are ways to evaluate your success. This is a risk factor test. Now, the other way that I've discussed this with Shaz and his team is that if I know that I have a young patient who's 25 with multiple cavities, not only am I going to come up with alternative preventative strategies that are beyond just brushing and flossing, I'm going to then see them more. I'm going to take maybe x-rays every 6 months or a year. I may be using transillumination to see earlier changes in class 2 caries. This will lead to more productivity in prevention, more recall visits. And let me just give you one more example, and not to hog the theater here. Perimucositis in implants represents over 50% of all implants placed. So if you know ahead of time that someone's high risk and you're placing an implant, you're going to be thinking, how do I prevent perimucositis, even if they have attached gingival tissue, which they should? So this is a thinking test. How do I become more preventative in my office and at their home? And is my therapy what should be recommended based on their risk profiles? If the patient doesn't engage in better prevention and understanding why, this test allows, as Beth said and Kathleen said, it allows them to understand how they can actually affect the outcome. And that is an important point in this test. Okay, I'm said and done.
There's another question here about the artificial intelligence. So when we first started this, we did the research for a long time, almost 3.5 years before we commercialized this test. We had developed our own AI engine, and the reason for it was we knew at a certain point the amount of genes we're looking at in our targeted genotyping, we could start using artificial intelligence to gain insights that we can't do as human beings as more and more data gets accumulated. Then OpenAI kind of just dropped OpenAI to the world. And so what we did was we pivoted and we went towards generative AI. And the usage for this is actually a little bit further down the road when we are doing thousands of samples. To be able to collate that kind of information from a human brain point of view will not make sense. And also to be able to give like insights beyond just how we're analyzing it will not make sense. So technology is amazing. And you'll start to see the AI component of this come about in the near future. I think Stephen's answering the question about the samples, right? Stephen, you can verbally answer it too.
Yeah, that's true. I can do that. So who owns the samples when they leave the office? So the samples go straight to Mount Sinai for testing. And once the test is done, they're thrown out. They're not tested for anything else unless you opt in, so that we can use the anonymized genetic information for other tests. That, however, if you can opt out at any time, if the patient opts out, we just go to their code, we pull out the code, and the sample's destroyed. So we wanted to make it very, very important that the ownership, I guess, of the genetic code is the actual patient. They can choose what they want to do with it. If they want it destroyed, we'll destroy it. So it's completely up to them. The whole purpose for us is to deliver the report.
Yeah, we're using one of Canada's largest academic genetic labs that are here in the Greater Toronto area. So the other good thing is too that the genetic data stays here in Canada. There's some tests out there where they're actually sending your genetic data abroad. So rest assured, you know, the genetic data, specifically the genetic samples, will remain here. And like Stephen said, if there's no use for it, or if the client decides they don't want to have any further things done to their genetic data, then it's destroyed by the lab.
Excellent, thank you. There's also a question here, Shaz or Suzanne, perhaps you can answer it regarding the expiry dates on the kits.
Yeah. So the expiry dates are, it has a lot more to do with, so the substrate in the collection tube is really good. I think like it's 18 months. Suzanne, is it something like 18 months? Like yeah, it's like 18 months. And that's really the rate limiter, is those 18 months. After that, in the process of actually doing the genetic sequencing, you know, there's something, the reagents that we use, they have an expiry as well of about 2 years, but those reagents are what's called programmed for this specific test in batches accordingly as the tests come in larger batches. So there's always enough reagents on hand, but we don't program more reagents than we need because they have about a 2-year expiry, right? So 18 months is really the one that people should be focused on. That's the shelf life.
Excellent, thank you. And we have one last question here. In case it's not addressed after, would this be covered under some clients' health or dental benefits? Do we know at this point? Beth and Kathleen, we kind of had a few discussions about this. Perhaps you can elaborate a little bit just from your own knowledge.
Yeah, so Kathleen shared the code. So the code across Canada would be 04101, which is essentially taking a microbiology sample. That's what the code is. That's the description of the code, or 04201. So I'll type those in the chat just to remind you, and that would be called taking Carrie's microbiology sample. So those would really be the two that you could be looking at, and they are covered. For those benefit plans that do have it covered, it's usually covered once per year per patient. If you're an independent dental hygienist, your code is going to be 00321. So I will just type that into the chat, but those are the codes that you can use.
Great, thank you, Beth. We have another question here. So when the patient file is kept in the dental office, how long does it stay in that file? So this is going to be through an online portal. So that online portal will be active forever. Is that
the
correct?
patient does have the option to have any of their data taken down, deleted. Again, like Dr. Moore said, the patient is the one who owns and controls their own data, but otherwise it would stay in the portal.
Perfect. And are there any other questions at this time?
Great.
I think that's everything.
So the CE certificates will be delivered. If you came on through the RDHU link, we will have the recording in your portal. The certificate will be there. And then with the Curion link, you'll get the recording and Anna will be sending out the certificate. So give us up to a week because we're into the long weekend this weekend.
Yeah. And thank you everyone for joining us this evening. Thank you to Lou, to Dr. Moore, Kathleen, Beth, Suzanne, and Shaz for joining us as well. We really appreciate everyone's time tonight.
Great.
Thank you for wonderful presentation. Good night
Thank
to all.
you, everybody. Have a great
Thank
long
you.
Bye.
Thank you.
Bye.